Hello and welcome to another intensive care hotline.com and intensivecareathome.com live stream. My name is Patrik Hutzel. I'm the host of the show today. And today's episode is about Ask Me Anything. You can ask me anything on this show live if you have a loved one in intensive care or anything related to intensive care at home. And I want to welcome you to this show. I do this YouTube live once a week, usually. Sometimes, depending on my schedule, I try to fit in a second one, but currently I'm doing it once a week, usually on a Sunday morning, 10:30 a.m. Sydney, Melbourne time, which is Saturday evening, 8:30 p.m. Eastern Standard Time in North America, which is 5:30 p.m. Pacific time, and 7:30 p.m. Central Time, 6:30 p.m. Mountain Time. So, welcome once again. Before we go into today's questions, I also want to welcome you if you're watching this on replay. My name is Patrik Hutzel. I'm a critical care nurse by background. I have been working in critical care for nearly 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in intensive care. I have been consulting and advocating for families in intensive care all over the world since 2013 as part of intensivecarehotline.com, and I can say without the slightest hint of exaggeration that we have saved lives with our consulting and advocacy. I'm also the founder and managing director of Intensive Care at Home. You can find more information at intensivecareathome.com. We basically send critical care nurses into the home, predominantly for long-term ventilated adults and children with tracheostomies, but also for BiPAP, CPAP ventilation, tracheostomy care without ventilation, home TPN, home IV infusions, port management, central line management, peak line management, Hickman's line management, as well as palliative care. More information you can find at intensivecareathome.com. Currently with Intensive Care at Home, we're operating all around Australia. We also provide level 2 and level 3 NDA support coordination. Okay, without further ado, let's go into today's question that I can read out. I'm getting so many questions every week that I can read them out, but there's a huge backlog. I'm probably reading out questions now that have come in maybe in January, but I'll have a quick look where we're up to. In the meantime, if you have questions, you can type them into the chat pad, or you are more than welcome to join me live on the stream here. You can click on the link that I'm just sharing here now. You can join me live on the show if you want to talk to me directly. And you don't need to go on camera. It depends on, I know some people don't want to go on camera. You can just talk to me without going on camera. Okay, here's the first question from Buttercup. Welcome, Buttercup. My friend had an open heart surgery and they kept him sedated because of heart enlargement, but he's not waking up. There's no stroke. I think that you're saying he's not waking up. You're saying he's not waiting up. I would assume you are saying he's not waking up. There is no stroke. Okay, so it's 5 days now. Okay, so Buttercup, if your friend had open heart surgery and they keep him sedated because of heart enlargement, that's interesting. Do you know what type of heart surgery he had? So the most common types of heart surgery are coronary artery bypass grafts, also known as valve replacement. Okay, thank you. Okay, so I argue if he had a valve replacement and his heart is still enlarged, maybe the new valve isn't working properly, right? Because he might have had an enlarged heart before surgery, and the valve replacement should fix that or at least improve it, right? So there might have been some complications. I don't know. I tell you from my experience, Buttercup, most of the time when patients are not being brought out of the induced coma after open heart surgery, it is either because of irregularities in heart rhythm, bleeding, right? God forbid, things like cardiac arrest, those are the most common things that I've seen when patients are not being brought out of the induced coma straight away, right? So first question is find out why, heart enlargement, it might be, but that could also mean that his ejection fraction has gone down significantly, right? Ejection fraction means or refers to the contractility of the heart, the pump function of the heart, right? So ask them if his ejection fraction has deteriorated as part of the surgery. Oh, I see. Yep, that makes sense. They said now the problem is fixed and they reduce the sedation, but he isn't waking up. Okay, yep, that makes sense. That makes sense. Okay. If that is the case, the first question that I have is, what sedatives has he been on, right? And quantity, how much, right? Also, after open heart surgery, your friend would have significant amounts of pain. Open heart surgery means they're cutting the chest open, right? Literally cracking the chest open, right? Very, very painful. When patients come out of surgery, there can be significant pain, as you can appreciate, and patients need morphine or fentanyl for a couple of days before they can go on to endone, for example, right, once they're off the ventilator. But your friend is not there yet because he's still in an induced coma. Now, so the first thing is he might simply had too much sedation, too many opiates, which will delay waking up. Number two, how long was surgery for? Okay, a valve replacement, from my experience, takes 3, 4, 5 hours maybe, right? Did it take longer? Were there any complications while he was in surgery? So let's just say surgery was 10 hours, right? That might delay waking up because your friend would have had so many more sedatives and opiates during surgery, right? It was 5 hours. Okay, you're well informed. That's good. 5 hours. Okay, that's not short, not crazy long either, but it's definitely not short. Okay, so then the next thing that needs to be looked at is sometimes, not all the time, sometimes after open heart surgery, patients can go into kidney failure. If your friend has gone into kidney failure, then it might simply take longer for sedatives and opiates to get out of the body system, right? To get processed through the kidneys. Okay, so therefore, there could be a delay in waking up just by simply the kidneys not functioning. Once again, a question for you to ask. Next, some patients after open heart surgery end up with an infection. That could be a pneumonia. It could be a urinary tract infection. It could be a bloodstream infection, right? If that is the case, patients in ICU are prone to infections, unfortunately, right? And if there is an infection, that might also delay your friend waking up. Next, you're saying the heart was enlarged in the beginning, which I'm not surprised by if there was a valve replacement. So let's just say the heart was enlarged. He might have been hemodynamically unstable. That means, he might have needed extra medications to maintain a stable blood pressure, right? Or a stable heart rate, right? That also might delay waking up. And it's one of the risks when doing open heart surgery, that the heart is not beating regularly. He might have needed a pacemaker, right? A temporary pacemaker, right? You're saying, I think that last one is the case. The last one, which was the last one I said? That irregular heart rhythm. irregular heart rhythm and that he might have been hemodynamically unstable. Now, also, when patients come out of open heart surgery, they often have heartbeat. Yeah, no surprises. Yeah, no surprises. Yeah. So he simply needed to be stabilized, and now they feel safe taking the sedatives off and opiates off. So he's in a good position to do that. But obviously now he's not waking up. That's a concern. Of course it is a concern. So if he's not waking up, the next step is to do a CT scan or an MRI scan of the brain, right? That is the next step. And if all that doesn't help, do an EEG, right? Lastly, or next, if he's still not waking up, again, someone needs to assess how many sedatives did he have, how many opiates did he have, has he potentially been over sedated, does he need an antidote, right? So for example, if he's had too much morphine or too much fentanyl, and that stops him from waking up, they may need to use an antidote. The antidote for morphine or fentanyl or for any opiates is naloxone. Okay, so that might wake him up, but then if he does wake up after giving naloxone, he will be in excruciating pain. So it's also a fine line, right? It's a fine line. Now, a lot of patients in ICU still get midazolam, which is a strong, long-acting sedative. Let's just say he had too much midazolam, right? Again, they could use the antidote, which is called flumazenil, right? That might also help in waking him up. Let's just say he didn't have midazolam and he had propofol or Precedex. They are short acting and he should be waking up after that. If he's not waking up, there is another issue. Okay, so you are saying they did a CT scan. They said no stroke. Well, that's positive. That is really positive, right? Did they do do you know whether he's in kidney failure or potentially in liver failure? That would also be helpful to know if he's in kidney failure or in liver failure, because that often also delays waking up. Also, would they consider to do an MRI scan next, right? And also, does he need input from a neurologist? No, he isn't. Okay. All right, that's good. That's good. That is not in kidney failure. Sometimes, buttercup, patients just need time. They just need time. And I'll tell you why. I have seen open heart surgery once. I was in the fortunate position during my training that I could watch open heart surgery. He isn't for kidney or liver failure. Yeah, that's good. That's good. Let me describe open heart surgery to you, because I think it is important to understand what actually happens in the operating room or in theaters. First off, they crack the chest open, then they take out the heart. They take out the heart and they stop the heart during open heart surgery. The bypass machine will take over the heart. Adam, if you're trying to... Okay, sorry. There was just someone trying to disturb this session, which is not appropriate. Okay, so so they crack open the chest, they take out the heart, right? And they stop the heart, right? They stop the heart, and And because they stop the heart, the bypass machine is taking over, right? And during that time, they also then have the heart in their hand, and they fiddle around with it, and this, and this, and that goes on for hours, right? That goes on for hours while the chest is open. So really, very difficult procedure. Okay, so with all of that said, and then the chest is open, right? It's huge. So therefore, it is not surprising that patients don't wake up. It's a huge procedure, right? So you got to give him some time. It's massive. Okay, so I hope that answers your question. And we can go from there. Do you have any other questions, Buttercup, in regards to this? If not, I will carry on with some of the questions that have come in during this week. And then we will go from there. What can you expect? Yep, good question. What can you expect? Patience. He needs to have a head-to-toe screening, right? He needs to have a head-to-toe screening, which is what they're doing now, right? They're screening him from head to toe, right, which is good. But patients, they need to keep stimulating him. They need to give him good nursing care. They need to wash him regularly, giving him good mouth care regularly, right? Giving him good mouth care regularly, turning him regularly, physical therapy, talking to him. It is unfortunately not surgery that is straightforward. Okay, it is not surgery that is straightforward, right? For some patients it is, but for some it isn't, right? Buttercup, are you the power of attorney for your friend, right? Are you the power of attorney for your friend? Are you getting this information firsthand or secondhand? Be patient and give it time. Okay, you're not the power of attorney. Yeah. So, that's a challenge because you're more or less getting information secondhand. I get it. Okay, so moving on to the next question from Triple Gemini. My loved one is in ICU on a ventilator due to lung infection. It's been 2 weeks. He's still very sedated, but opened his eyes, but still not responsive. Triple Gemini, is your loved one on a breathing tube or on a tracheostomy? That would be really important to understand, whether your loved one is on a breathing tube or on a tracheostomy. That would be really important to understand. Tube, okay. So why is he still sedated? Do you know why he's still sedated? And why have they not been able to extubate him yet? Do you know why? And has a tracheostomy been discussed? That would be really important to know. And is there anything else besides the lung infection? That is another important factor here, Triple Gemini. While I'm waiting for your response, and it might be easiest, Triple Gemini, if you just come on the call here, if you click on this link here that I'm just posting now, because it's easiest if you just come on the call here and we can discuss it here. So you can just click on the link here and you can join me on the call. In the meantime, I'll just read out another question that I had during the week while I'm waiting for either to join me here on the call or to type your answer into the chat pad. Okay, so email from James. Hi, Patrick. I wish I had known about your advocacy and consulting last year. My mum's doctor forced a PEG tube on her, and no one would work with her to try to get her to be able to swallow again. She got aspiration pneumonia, and the hospital wouldn't even try to help her. They forced the breathing tube down her throat and just let her get worse, eventually sending her to an LTAC, where she got 5 times stage 4 bed sores and sepsis. She passed away on May the 26th of last year. I have tried filing a lawsuit against the place she passed away in, but no law firm will take the case. They say her bed sores were inevitable. I am disabled myself. I live on a fixed income, and I don't think that place should just get away with the neglect they did for my mother. Wow, that's powerful stuff, James. Well, first off, here is one thing that I want to point out here. You're saying your mum's doctor forced a PEG tube on her. Well, no one can force a PEG tube for anyone unless you give consent, right? If you are the power of attorney and your family member cannot make decisions for themselves, and you are the power of attorney, right? No one can force anything on you, okay? This comes back to what I'm saying over and over again. You also need to take full responsibility, okay? Please, and I know it might sound harsh, but you need to take full responsibility for what's happening and for what's not happening. Okay, only then can you really make a difference, right? And this is why I am so opposed to a PEG tube for most patients, not for some patients. But this is why I'm so opposed to, for most patients, to a PEG tube, because it gives health professionals the perception that a PEG tube is permanent. The alternative to a PEG tube is a nasogastric tube, right? A nasogastric tube gives health professionals and also patients and families the perception of it's temporary, i.e., this patient needs to learn to eat and drink again so we can get rid of the nasogastric tube. And it's no more difficult than pulling out the nasogastric tube, right? It's also no more difficult than inserting a nasogastric tube. It doesn't require surgery, whereas a PEG tube requires surgery. It's a surgical procedure, right? So what would you do if it was up to you? Would you do a surgical procedure or just a nasogastric tube, and once your loved one can eat and drink, you just take it out, right? Why would you go through a surgical procedure, right? Doesn't make a lot of sense as far as I'm concerned, okay? And this is exactly what James is saying here. No one would work with her, with my mom, to get her to able to swallow again. That is exactly my point. That is exactly my point. Now, when do you need a when would you need a tracheostomy tube, right? When would you need a PEG tube? Well, you need a PEG tube when someone can't be weaned off the ventilator beyond the shadow of a doubt. That is for someone with, spinal injuries, high spinal injuries. That is for someone with motor neuron disease, cerebral palsy. There are conditions where a PEG tube is inevitable at some point, or SMA, spinal muscular atrophy for kids. There are situations where a PEG tube, is inevitable. But just like James pointed out in his email, it should be used for a patient's best interest, not for a hospital's best interest. Okay, so I hope that explains the situation there. Nick, I will get you on the call so you can ask your question. Hi, Nick. Welcome to the show. How can I help you?
Hi, how are you?
I'm very well, thank you. How are you?
Good. Um, so my so I'm out of state and I was calling in, getting updates morning and night, and then me and his family had a little argument, and so they banned me basically from the hospital, from everything.
Yep.
Um, so all I know right now is lung infection. He's been in there for 2 weeks. He is on the tube still. It is not pneumonia. Um, they tried to get him off of the tube, and they just did it like cold turkey. They didn't wean him off or anything, and he freaked out, and his blood pressure went sky high, and they had to put him back on the ventilator with 100% oxygen. So that's why.
Okay. And therein, okay, thank you. And this is good that you're explaining that, because therein lies the answer why A, they can't extubate him yet, and B, why they probably haven't discussed a tracheostomy yet either. If he's on 100% of oxygen, it wouldn't be safe to A, extubate him, and it wouldn't be safe to B, do a tracheostomy. Do you know what
Well,
I mean when I talk about a tracheostomy?
yes, yes.
Right.
He actually right now is only on 40% oxygen.
Okay.
They
Okay.
got him down to 40%, but it's the lung infection that is making it difficult. But he is breathing along with the tube, they said.
Okay. So he's breathing, but he's not waking up.
Right, right. And yesterday he actually opened his eyes, and he opened his eyes, but he's not responsive.
He's opened his eyes, but he's not responsive. Okay. And they stopped sedation?
He's still no, he's still sedated.
Okay. Okay. And it's been 2 weeks now, has it?
Yes.
And there's nothing else besides the pneumonia that you're aware of.
Correct.
Okay. So if he's now on 40% of oxygen, right, that's one ingredient to do a tracheostomy, right? But there are other ingredients too. So, for example, he would be on a PEEP, and I don't want to get too medical here, but if he was on 100% of oxygen, there's a very high chance that he's got a high PEEP, right?
Yes.
And if oxygen is not less than 40%, and if PEEP is not less than 10, it wouldn't be safe to do a tracheostomy. So that's where the delay might be to do a tracheostomy, because I don't know how much research you've done, but after about 2 weeks of mechanical ventilation and the inability to wean, it is recommended to do a tracheostomy, if that makes sense. Are you following?
Yes, that is what I've been doing, a ton of research, of course. And that is, yes, I figured that was the next step, because 2 weeks is, I'm thinking at that point. But as far as I know, they have not mentioned that.
Right. Right. Okay. How long ago was it that he was on 100% of oxygen? How long ago?
I'm sorry.
You mentioned earlier he was on 100% of oxygen
Yeah, that was 5 days ago.
5 days ago. Okay, so now he's down to 40%.
Yes.
Okay, again, A lot of it depends now, what is his PEEP like? And if PEEP is less than 10 and oxygen is less than 40%, they should be getting very close of doing a tracheostomy, given that I'm hearing he's not waking up.
Okay. Okay. Now, you are not really for tracheostomy, correct?
Well, I tell you what it depends on. A tracheostomy can be a wonderful thing, right? And a tracheostomy has their time and their place. And a tracheostomy is also in the context of which country. I presume you are in the United States?
Correct.
Right. So I tell you why. It really depends on circumstances and the country. So in countries like Australia or in the UK, a tracheostomy is often being placed with the goal to wean a patient off the ventilator as quickly as possible. That, I believe, is the original purpose of a tracheostomy, and that's a good purpose. In the United States, however, if your friend is going, if your fiance, I think it was, is going to have a tracheostomy, they will try and send him to an LTAC as quickly as possible. And I'm very opposed to that. I'm very opposed of a tracheostomy being used to send patients to LTAC. That is unique for the United States. Do you know what I'm talking about? Do you know what I mean by LTAC?
No, I don't know what Altec is exactly. I have
Yeah.
no idea.
Yeah, sure. So in the United States in particular, a lot of patients in ICU end up with a tracheostomy if they can't be weaned off the ventilator. They end up with a PEG tube, and then ICUs want to send them out to an LTAC. LTAC stands for long-term acute care facility. From my experience, it's not even the beta version of a nursing home, right? And therefore, patients go to LTAC simply to save the health insurance money and to save the ICU, or to free up a bed in ICU, which they so desperately need, but it's not designed for clinical care. Then patients go to LTAC and then nothing's happening. Families get sold on LTAC where ICUs are saying, oh, your family member goes to LTAC, they're specialized in weaning patients off the ventilator. And I say, well, that's a whole lot of nonsense. Just look up LTAC reviews online. Just look them up. They're shocking. Absolutely shocking. We're getting phone calls every week from families in LTAC saying, please help me to get my loved one back to ICU. They're finding out too late that it's all designed to save money, but not for clinical care, right? So that's the bottom line, unfortunately, and that's why it's so important that families are informed about the next step. So I am not opposed to a trach. If the ICU where your family member is at, if they're using the tracheostomy to wean him off in the ICU, fantastic. Job done. Fantastic. If they are using the tracheostomy to send him to LTAC, ooh, red flags everywhere.
Okay. What? How do I find out what what the purpose of the trach will be?
Yeah,
What?
good question. Yeah, just by simply asking them, what's your plan? There's also what we've seen over the years, Nick, is we've seen a lot of bait and switch. So what I mean by that is, again, ICUs are talking to families and saying, oh, your family member should have a tracheostomy to wean your family member off the ventilator. That's great. That should be the purpose of a tracheostomy. But what they're not saying is, once they do have a tracheostomy and a PEG, I'll talk about the PEG separately in a minute, that the ultimate goal is to send them to LTAC, right? And that is wrong in my mind. That is absolutely wrong, right? So, but there is a way to potentially work around that we've found out through trial and error. So let's just say your family gets approached about doing a trach for your loved one, often they also ask for a PEG tube, right? And our advice is tracheostomy, yes, if the patient gets weaned off the ventilator, you know, as soon as the tracheostomy has been done, because it is easier to wean off the ventilator with a tracheostomy than with a breathing tube after a certain period of time, i.e. sort of the 2-week cutoff, the 2-week mark. But do not give consent to a PEG tube.
I just have one question.
Sorry, I didn't get that. You're dropping. Try again.
With the trach, is that for oxygen or is that just for food source?
Ventilator. Trach is just ventilation. Trach.
It's for ventilation.
Trach,
okay.
So currently your loved one is ventilated through a breathing tube in the mouth that's going into the lungs, right? That's very uncomfortable.
Okay.
A tracheostomy sits in the neck, right? It sits in the neck, in the lungs. It's much easier to tolerate. Much easier to tolerate. That's why sedation and opiates can come off straight away, most of the time.
Okay.
Right? One of the reasons your family member is sedated and on opiates at the moment is because of the discomfort that a breathing tube is causing.
I get it. Okay.
Right?
Okay.
So, and that's why I'm sort of saying you will, I know for anyone watching, you sometimes may wonder if you watch my videos, are you for tracheostomy? Are you against a tracheostomy? And I go like, a tracheostomy is a wonderful thing for the right patient at the right time. Tracheostomy can be a terrible thing for the wrong patient at the wrong time.
I see. Okay.
Right? It's not a one size fits all. And because I have an international audience here, right? It is also dependent on the country.
Okay.
Right. So, and I argue absolute no to PEG tube in this situation. Not, like I mentioned, if someone, God forbid, has a high spinal injury, has motor neuron disease, has cerebral palsy, has SMA, a PEG tube is inevitable. But in your loved one situation, I don't think he needs a PEG tube at this stage, from what you're sharing with me.
Okay. So with the trachea, then he has to have a PIC too? A PIC?
No.
Okay.
Definitely not here. So this goes even deeper. This goes even deeper now. So let me talk about the PEG tube. So currently your loved one would most likely have a nasogastric tube, which is a feeding tube in the nose going into the stomach. They would get nutrition through that.
Yeah.
Okay. That's perfectly fine. It's a temporary device, and that's perfectly fine. Now, again, in the United States, this is very unique to the United States, right? When patients or families are being asked to consent to a tracheostomy in ICU, they're also often being asked to give consent to a PEG tube. I don't know whether you were here a minute ago when I read out the email from James, who talked about his mum having a PEG tube and nobody informed him what it really is. I don't know whether you've heard me read out the email and comment on that, because that sort of illustrates the issue about the PEG tube. So the issue with the PEG tube is A, it requires surgery. It's sort of a minor surgical procedure, but at the end of the day, it's still surgery, right? And it gives health professionals a perception of, oh, this person will never eat and drink again because they've got a PEG tube, right? That is the perception, unfortunately, right? And no one will bother trying to wean someone off the ventilator, wean someone off the PEG tube, to get them to breathe again and eat and drink again, right? Whereas if you keep the nasogastric tube in, the nasogastric tube gives the perception of it's a temporary device. We need to wean this patient off the ventilator, need to take the nasogastric tube out and start eating and drinking again. So, a lot of what's happening in ICUs in the US in particular is based around the pathway the insurances have laid out. And the pathway the insurances have laid out is, well, a couple of weeks in ICU, if they can't be weaned off the ventilator, let's do a trach and let's do a PEG and let's send them to LTAC where it's much cheaper to look after them. But they're missing critical steps. The critical step that they're missing is, have we tried hard enough to avoid the trach and the PEG and wean them off the ventilator? So that brings me, again, in comparison to other countries, other English-speaking countries, Australia, the UK, but many European countries, LTACs don't exist, right? So the ICUs are under pressure to wean someone off a ventilator. They are under real pressure, and they make it happen most of the time. Whereas in the US, I believe there's complacency in ICUs now because they've got the LTACs on the other end. So it's a very complex, it's a minefield. It's a real minefield. Having worked in multiple countries, Nick, I argue in most English-speaking countries, Australia, the UK, New Zealand, Canada even, the number of patients with a PEG tube in ICU is minimal. The number of patients with a PEG tube in the US in ICU is huge, right?
Wow.
For no good reason,
Wow.
right? The
Oh,
reason is to keep the ICU satisfied and keep the LTAC satisfied and keep the insurances satisfied. Well, what about patient outcome?
right. They're not looking at that. They're looking at money side. They're looking at the
They're looking at money side. It's shocking. It is absolutely shocking. Just this week alone, we helped 2 of our clients with our advocacy to go from LTAC back to ICU.
Oh, so wow. So wow. Good for you. Good for you.
But that should never happen in the
Never
first
happened.
place.
It's
It should have never
right.
happened in the first place.
Exactly.
Right. So
Oh,
it
that's
is
horrible.
the system is flawed beyond anything that anyone can comprehend, I believe. So, but at least you've now got an overview of what questions to ask. What I can see with the information you've given me, Nick, probably yes to a tracheostomy, probably yes to that, no to a PEG tube. Here is another thing that's important. We have found that if families stay away from giving consent to a PEG tube, let's just say a tracheostomy is needed, right? And the ICU is pushing you to do a PEG as well, just stay clear of the PEG. That in and of itself is often enough for patients to stay in ICU and not go to LTAC. And here's the reason why. Most LTACs cannot take patients with a nasogastric tube. They can't look after it, which should tell you everything about the skill level that you're getting there. It's non-existent.
Oh my gosh. Oh my gosh. Okay.
Right?
I feel like now since it's been 2 weeks, like like he's overdue. Like they're probably already
Yeah,
thinking
it's
about
overdue. He's probably overdue.
right,
But
right.
but but the reason he's probably overdue is simply his ventilation needs have been so high that no surgeon would touch him to do a tracheostomy. The risk of a patient dying on the operating table doing a tracheostomy on 100% of oxygen is too high.
Okay,
So,
I
so
see.
it, right, it makes sense to me
Okay,
that
makes sense.
it makes sense to me, right? They're erring on the side of they're erring on the side of caution,
Okay, okay.
most likely, right? Now,
How long have how can a patient stay in the ICU for months or
years. I've seen up to 18 months.
oh my gosh, okay, okay, okay. So no pick, just no pick.
Well. Look. The sooner your family member can get off that ventilator, whether with or without a tracheostomy, the better, right? Time is of essence. You don't want somebody to stay in ICU for 18 months, right? You don't.
Right. No, of course not. Of course not.
But we're talking about extremes here.
Right. Okay. Now I guess they're just waiting for the infection to clear up, I guess. But keeping him
That,
on the ventilator is scary. I
it's super
read
scary.
so much.
Super,
Yes, yes. And they can't. They're concerned a little bit about his brain activity as well because when they took him off the ventilator, they were telling him, um, raise your finger or raise your foot, and he was too busy freaking out to be able to even do anything like that.
yeah. That's and the reality is that most patients, when they eventually come out of the coma, they are confused, they're agitated, they're hallucinating. Unfortunately, a recovery process, what your loved one is going, it's not going to be straightforward. Very rarely is it straightforward. So the next challenge lies ahead once he's off the ventilator.
Right. It's like a whole another big
And
obstacle after the
that's
ventilator.
right. That's right. And
Okay.
that's why timing is so critical.
Is yes.
The longer it goes on, the higher the risk for complications, of course. But a lot on the other hand, a lot of patients have come through this fine as well, but it's a struggle. Let's call it for what it is. It's a struggle.
Right. Well, I'm gonna be there for him. So we'll get through it. We'll get through it. Just
and
yeah.
and that's the right attitude to have, that you will get through it. And it's one of the biggest challenges that I believe families can ever experience. It's, it's terrible. It's not for the
This is
faint heart.
this is literally the scariest thing I've ever been through. And like I said, I'm not even in the same state, and it just makes it. It's yeah. It's horrible, but
Of course,
I appreciate you so much. I binge watched all your videos, and I can't believe I caught you live right now. It was meant to be. I truly appreciate your time and thank you so much.
it's a great pleasure. All the best to you and your family, Nick.
Thank you so much. You have a good night.
Same to you. Thank you.
Thanks. Bye bye.
Thank you. Bye. All right. Okay. Helene, you're saying, would you disapprove, and good to see you again, Helene. Would you disprove a PEG tube for a patient who suffered hypoxia, encephalopathy, and permanent brain damage? It's not whether I approve or disapprove, Helene. It's like I keep saying, it's not a one size fits all. It depends on what families want. It depends what the patients would want. It's not a one size fits all. If a patient, for example, has an advanced care directive and says, hey, if I'm in a situation like you're describing here, I'd rather die, then I would not approve of a PEG tube. Now, if a patient has an advanced care directive and says, hey, no matter what happens, I want everything to be done, then I believe a PEG tube is reasonable, right? So it really depends. I am not here to be a judge. I am here to facilitate what families and patients perceive is in their best interest, right? So it's not a one size fits all. Okay, so Buttercup, you're saying you got more info on your friend, his left ventricle is weak. That's interesting because I'm sure the valve surgery would have been, the goal would have been to strengthen his left ventricle. If his left ventricle is weak, I strongly suggest you find out what his ejection fraction is, right? The term is ejection fraction. In a buff situation, could that cause delayed merge? What do you mean by that? Don't understand what you mean by that. With the left ventricle being weak, I would find out what his ejection fraction is, because ejection fraction refers to the contractility of the heart, right? And that refers to the pump function of the heart. If he's weak, yeah, if his heart is weak, that could delay him waking up. Absolutely. Absolutely. Yeah. Because if his left ventricle is weak, it means his heart is weak. Right? So could absolutely delay him waking up. That also means they have to optimize his medications. Right? He might be on inotropes or vasopressors for the weakness of the heart. Okay, which may also delay him waking up. Right? There's probably a lot of rejigging they're going to do with his medications. Right? So I would look into that if I was you. Okay. That may answer the question. There could be other, it's often multifactorial, Buttercup. It's often not just the heart. He might simply have too many sedatives in his system. Another thing that I forgot to mention earlier is that he might have been paralyzed. And what I mean with paralyzed is chemically paralyzed with medications. If he has been paralyzed, maybe he was breathing against the ventilator, maybe he was shaking, shivering, I don't know. But that is also sometimes the case in ICU. If he has been paralyzed, there may also be a delay in waking up. It's, many things during critical illness are multifactorial. It's not just one thing that you can pinpoint. Sometimes it is, but it's often multifactorial. Right? Okay. So I think we've covered a lot of ground today in terms of, once again, the whole LTAC issue in the US in particular, and that sometimes I am all for a tracheostomy and sometimes I'm not. It is, once again, and not a one size fits all. Every case is individual, it's unique, and it needs to be looked at from, a number of angles in order to make the right decision. The one thing that I want to leave you with here today is the goal always needs to be to wean someone off the ventilator as quickly as possible. And the goal always needs to be to avoid the tracheostomy to begin with. Now, there comes a point where tracheostomy might not be avoidable, right? And that's when a tracheostomy is actually a good thing, right? But from day one, they need to work on trying to avoid the tracheostomy as much as possible. And I just don't see it often enough currently, especially in the United States. where the LTAC seems to be the one size fits all, which is very concerning to me. Helen, you're saying, Patrick, can excessive IV fluids overload cause pulmonary embolism? Look, I don't think so, but I would have to look that up. I argue no, because pulmonary embolism most of the time is caused by a DVT, by a deep vein thrombosis, right? I argue no, but I'm sure there are cases where excessive fluid overload might have caused a PE. But if I type this into Google, I would be, I probably have to look that up myself. But I argue no, from my experience, it's often caused by a DVT, because what often happens after a PE, patients end up with an IVC filter. An IVC filter is placed in the femoral vein around the hip side to stop the thrombus that's developed in the veins moving upwards and causes a PE. So I hope that answers that question. Now I'm going to wrap this up for today. Now I really appreciate, and thank you for coming on and for asking all these questions. I really appreciate it. I also appreciate if you subscribe to my YouTube channel for regular updates and for the YouTube lives that you get notified for. I also appreciate if you give this video a like, if you share the video with your friends and families, if you click the notification bell, if you comment below even after the video, so I know what you want to see next. Like I said, I do these YouTube lives once a week, usually Sunday morning, 10:30 a.m. Sydney, Melbourne time, which is 8:30 p.m. currently Eastern Standard Time in North America, on a Saturday, 5:30 p.m. Pacific time on a Saturday. We also have a membership for families of critically ill patients in intensive care that you can get access to at intensivecarehotline.com if you click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in a membership area and via email, and we answer all your questions in the membership. I also offer one-on-one consulting and advocacy over the phone, Skype, Zoom, WhatsApp, whichever medium works best for you. I talk to you and your families directly. I talk to doctors and nurses directly, and the dynamics often change when I talk to doctors and nurses directly, because I ask all the questions that you haven't even considered asking, but must be asked when you have a loved one in intensive care, so that you can make informed decisions, you have peace of mind, control, power, and influence, and so that your loved one gets best care and treatment. I also represent you in family meetings with intensive care teams. We also offer medical record reviews in real time, so that you can get a second opinion in real time. We also offer medical record reviews after intensive care. If you have unanswered questions, if you need closure, or if you are suspecting medical negligence. And all of that you get at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or send an email to support@intensivecarehotline.com. If you need intensive care at home, go to intensivecareathome.com. Again, call us on one of the numbers on the top of our website, or send an email to info@intensivecareathome.com. We are currently operating all around Australia, in all major capital cities and in regional and rural areas with intensive care at home. With Intensive Care Hotline, we operate all around the world. With Intensive Care at Home, we are an NDIS approved service provider, TAC and WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, DVA all around Australia. We have received funding from public hospitals, private health funds, as well as departments of health. We are also providing level 2 and level 3 NDIS support coordination. We're also providing NDIS nursing assessments and any other nursing assessments you might need. And I'm going to leave it here now. I'm going to wrap this up. Thank you once again for all your support. I will be back again next week. Look out for my YouTube quick tips during the week. Thanks for your support, and thanks for watching. Give the video a like and subscribe to my YouTube channel, and share the video with your friends and families, and share it far and wide, so that everyone knows about what's happening in intensive care, what's important for families in intensive care. Take care for now. This is Patrik Hutzel from intensivecare.com, and I will talk to you soon. Take care.